Hello and welcome everyone to the Georgia Flex Quality Improvement Project meeting. Today is April 22nd, 2025. Welcome everyone. I see folks signing in, so that's great. Feel free to use the chat. Let me know you're here. How's the weather outside your window today? Okay, we have a great workshop meeting today planned. Briefly, we'll talk about the NBQuip core measure set and information guide, an update as we have a few changes for the next couple of months. We're also going to open it up to our own Georgia Flex Quality Council. So we have Shannon Hart from Candler County presenting today, as well as Dexter Shook from Chatouche. So we're going to have a quality council. And once they present, you can chat, questions, comments, insights, challenges, anything you'd like. So this is your chance, peer-to-peer learning, as they describe their hospital action plans. And then we'll go over some updates and resources. Any questions at the final couple of minutes of the session today, just let us know. My name is Karen Holtz. I also have Mel Brown, my colleague, on the line with us today. And the link to the slides is posted in chat. We'll make sure you get the slides today. Just wanted to share with you, and you may have seen this, the NBQuip 2025 Measure Core Set Information Guide version 2.2 that was released in March. Just letting you know that we will discontinue the hospital commitment to health equity, the red arrow under global measures. And we'll pick up under safe use of opioids, under patient safety. So we will begin safe use of opioids probably in September. We will continue under the care coordination, the social drivers of health screening, and the social drivers of health screening positive, your rate, the screening rate. The link is there if you'd like to check that out. And also with safe use of opioids, let's talk about this for a minute. It's the different deadline, February 28th. So that's an annual submission. So you may know about the safe use of opioids. The measure description is there. It's also posted on our webpage, and I'll send out the link as well. So, quick polling question. Does your hospital have a Pyxis or another automated medication dispenser in your hospital? As we start to think about safe use of opioids and how to teach you and have work group sessions. So if you can hit yes, no, or I don't know. Yes, 92%. Okay, no. Looks like maybe one person. Okay. Thank you. Also talking about safe use of opioids, and this is for everyone. What letter grade would you give your hospital for the safe use of opioids? Your opioid stewardship committee, what letter grade would you give your hospital? A, B, C, D? Just put it in chat. It's not a polling question, but if you could put it in chat.
Karen, can you go back to that measure description again? Because it's the combination of opioids with other, as people say, benzos. I think that's one of the things, but we know it's so much more than that. It's really the whole use of opioids, and we'll have a pharmacist join our session starting at September for this. So that's 18 and older, on 2 or more opioids, or an opioid and a benzodiazepine concurrently at discharge. So as they go home, post-surgery, post-fall, post-episode that they need pain medication.
Okay, thank you, Kelly, Bonnie, Robin, Shannon, Rebecca. Letter B, B grades. Okay. So there's room for improvement. That's what I understand. Okay. So we want to find the gaps. Does your hospital have an opioid stewardship committee? Sometimes smaller hospitals have the opioid stewardship committee along with the antibiotic stewardship committee. No opioid stewardship. No committee, but pharmacist oversees with MDs. Okay. No P&T committee. Pharmacy and therapeutics. Very good. Okay. The QAPI monthly meeting. Very good. Okay, this helps our pharmacists to understand where we are. We're just trying to level set, and as we begin to look at some interventions, best practices. Okay. All right, great. Thank you, everyone. We're now in the attestation period, April 1st to May 15th. We're going to continue the social determinants of health 1 and 2. So your screening and your screen positive rate. And from what I understand, it's real quick, this is the deadline period. So May 15th, 2025, the submission deadline in the IQR program. The link is also there. And so this slide shows survey completion for the homework assignment 2A, 2B, 2C. So this is that domain 2, social determinants of health. Thank you very much. We had 22 out of the 28 hospitals who completed. Great work. You're doing it, you're attesting to it, it's valid. So you all shouldn't have any problem with the attestation. And today we're going to talk about data analysis. This is domain 3, key performance outcomes or process of care outcomes, such as 30-day readmissions, or if you're looking at the discharge process, how are you stratifying it by race, by the social determinants of health, such as transportation, food insecurity, and how are you displaying your gaps on your dashboard? Do you have a quality improvement team? Are you involved with case management? Are you involved with pharmacy? How are you working to reduce your readmissions? So that's today's session, and we have 2 hospitals that will share their action plans. I sent out a PowerPoint template and asked that you just fill in your hospital action plans. What are you working on? What are your lessons learned? Any data you have in charts and graphs? And things change. We know things are going to change. Leadership has changed. So your goals may change. For April 22nd, we have Shannon from Candler County. And today we also have Chatuge Regional. So we have Dexter Shook will be presenting as well. If Blakely, Clinch, or Early Medical are on, please send me something in chat. What other date would you like to present? All hospitals are presenting with each other. Feel free to comment in chat. This is very informal. Ask questions. And then for May 27th, I have Effingham, Jasper, Atrium Health Peach, Archibald Brooks, Atrium Health Floyd, Alberts, and Jenkins County. So Kayla, I know you wanted to move your date for Jenkins County, so let me know if May 27th works. And I'll be sending the PowerPoint slide. Let me know if you need any assistance. Mel and I are happy to help. So we'll be doing this all summer, sharing. Okay, we have Chatuge Regional. It's up first, and I have Dexter Shook. Let's see if Dexter can unmute.
Yes, I should. Can you hear me?
Yes, we can. Hello, good morning. How are you?
Doing well, thank you. Chatuge Regional Hospital, a little bit about the hospital. Of course, we're a critical access hospital. We have swing beds. We do swing bed services, have an emergency room, 6-bed ER. We do outpatient services. We have a sleep lab across the street from the main campus. We have a pain clinic. We do pain procedures here in the hospital, but we don't do any surgeries per se. We're in Hiwassee, which is right up next to, we're in Towns County next to the North Carolina line. So we have patients come from North Carolina as well as, of course, Georgia. We looked at the social determinants of health. We're not using real data because our population is white. We may have one or two Hispanic people, and maybe I think there might be one family that's a black family that lives in the area. So most of our people are all white. They're retired. This is a retirement area. It's a place that a lot of people like to come to and vacation, all that, because of Lake Chatuba. So we looked at the social determinants of health and kind of looked at that out. We had 172 people that were did do the social determinants of health, and out of those, we had only 15 people that said they were concerned about transportation, utility, food, or housing. We looked at the readmissions from these people who are concerned about one of the four determined. We didn't have anybody that said they were concerned about safety. Had no one for that, so we only really had four social determinants of health that we were looking at. We had, out of all of the people that tested positive, we only had 3 readmissions. And those readmissions, we looked closer at that. One of them was a 79-year-old veteran. He has Medicare Advantage. He was concerned about transportation issues. He came in 2 times with UTI. He has AFib, chronic Foley and dwelling Foley. He's had CBAs, diabetes. He has been offered nursing home placement, but he refuses. He does not want to discuss that. He wants to be at home. So he has been admitted, of course, 2 times within 30 days, and he was sent home with home health, very adamant that he was not going to go to the nursing home. We had one person who was a readmission who was concerned about food, and she is a 93-year-old lady who lives alone. COPD, CHF, pulmonary hypertension, AFib. She does not want to leave home for multiple reasons. She has a daughter who lives in Florida, and she was concerned about food, but she does have groceries, medicines, all that is delivered to her home. She had dyspnea, came in the first time with dyspnea on exertion, and then she came back within 30 days with community-acquired pneumonia. She was discharged both times home with home health. She is adamant that she is not leaving home. Mm-hmm. We had another lady, a 46-year-old female, who also was concerned about food. She came in with diverticulitis. Then she comes back in with chest pain, with vomiting, and anxiety. She's unemployed. She's on Medicaid. She has endometriosis, GERD, hiatal hernia. She's a chronic marijuana user. She has cardiomyopathy, chronic elevated troponins. She was concerned about food, but we did offer, of course, all these people. We've got a wonderful pamphlet that we share with anyone who has any concerns, that there's all kinds of places that we can help them reach out, or they can reach out for themselves if they don't want us to help them. So we did not see any kind of correlation with the readmissions just because they came back in wanting to have something to eat. I think most of these people were just, they're adamant that they don't want to leave home, so we have to accommodate that. But we had 5 people. Some of these screened positive for more than one, but we had 5 people in our adjacent county, Hayesville, North Carolina, and Clay County, We had 2 people screen positive in Blairsville, which is in Union County, which is where our mothership, Union General Hospital, is. We're part of Union General Health System. We had 1 person in Young Harris, which is in Towns County. Hiawassee, we had 12 people, and we had 1 person in Murphy, North Carolina, which is in Cherokee County, North Carolina, that tested positive. We have resources for both for both North Carolina and Georgia, for our people who come in and test positive. Our biggest one was food. We had 81% tested, they screened positive for food concerns. Most of those were in 8 of them were in Hiawassee, 5 were in Hayesville, North Carolina, 2 were in Blairsville, 1 in Young Harris, and 1 in Murphy. We had transportation was the next one, 38%. We had 2 in Hayesville, 6 in Hiawassee, and 1 in Blairsville. We have good transportation availability for these people, though, and we have offered them, and they are aware of transportation availability. We had, next was housing. We had 24% that were concerned about housing. Well, that would be 1 in Blairsville and 4 in Hiawassee. And we do have housing options for these people as well. Then the last was utility, which is 14%, but that means 1 in Blairsville, 1 in Hayesville, North Carolina, and 1 in Hiawassee. We do have with our local EMC, we have services that can help them pay for their utility bill, and they can get it at a reduced rate, et cetera, et cetera. So we've got lots of good resources, and for the most part, that's about all I've got. Melody, was there anything else you wanted me to mention?
Dexter, thank you so much for sharing your story today. And I think this was maybe a little bit of an eye opener, as Dexter and I talked about 3 weeks ago. I believe we had a conversation, and I know that he is not unique to the issues that sometimes they are looking at, because they are on the Georgia North Carolina line. And so, that kind of puts you in a predicament, I guess, Dexter, you might say, to know what you have for your resources right around you. But once they cross over the state line, sometimes even, I think one of your patients, as we discussed, has Medicaid in North Carolina. So, and we have several of you on the phone today. You are in what we call bordering states. You're bordering Alabama and Florida, as well as, Dexter with North Carolina. So, and we may have someone over bordering South Carolina. So that makes you have to think truly outside of your box right around you as to, 1, their payment system, 2, what resources do you maybe have to try to connect them with as they cross over that state line. So Dexter, I appreciate you bringing that out today. And, as you all think about, as, Karen had said earlier, these are your stories that Sharon, that you're in the trenches, you're there with everything and having to really do this. So again, lean on each other as, Dexter, I know you've done a great job with the food insecurity sources over in North Carolina for both the Murphy and Hayesville, I believe. But, that's one thing to think about once they cross over those lines. What's different there, or are there resources maybe in Georgia that they could use? Sometimes there may be, sometimes there may not be, with the outside services. I do appreciate you bringing out, that y'all have really looked into transportation. We know that probably everyone on this call today has an issue with transportation and what that looks like. And then, you brought up, you do have one patient. He is a VA patient. So again, that can, as far as resources are concerned, he might actually qualify for more resources or less according to what you're looking at. So you have to look at him a little differently. So I appreciate you presenting these 3 cases basically, and then breaking down your data into your geographical locations. I think that was very good to give you an idea of what's available in each one of your different locations that you serve. So thank you for that. Hopefully everybody got something out of this, that maybe if y'all have questions for Dexter, now would be the time, chat them or just come off mute and ask, because he's done a lot of work, and I appreciate the slide, the way that you have broken this down, but as well as you have the data behind this of where your patients are, coming from. And I think you broke that down really well. So if y'all got questions for Dexter, please ask. And again, Dexter, thank you for sharing.
Yes, thank you, Mel. Thank you, Dexter. Great. Quick, couple questions. Tell me about your food resources. Are they food banks, food pantries, some type of delivery service for your food insecurities?
All of the above.
Okay.
We have
Good.
We have food banks for Towns County, Union County, Clay County, a number of churches that we have reached out to that will help with food insecurity with our patients, and we have the phone numbers and the addresses for all of these things on our pamphlet. We've got a nice laminated, some kind of pamphlet that's really nice that they did a good job with. It's a community resource guide. It's pocket edition, but it's got all of the things that we offer for any of the domains on this pamphlet, and then in addition to that, there's other things such as the family and children's services, child and parent services, food stamps, Medicaid. We've got all of the help and crisis lines, senior centers. Our average age of the people that tested, or I keep saying tested, but came out positive for one of the four, is about 67 years old. So we've got an elderly, as I told you earlier, we've got an elderly population, and I think that we offer a lot of good opportunities for these people if they are having issues with one of those domains.
Okay. And tell me about your transportation resources.
Transportation, we have, let's see, let me find it here. We've got the Towns County Transportation. We've got a transportation bus that picks people up, and it's very, very reasonable price. It's Towns County Transit, and the fees is one way is $3 for the first mile, and then 50 cents for each additional mile. Union County Transportation is basically the same, and it's Monday, Tuesday, Thursday, and Friday, and that's for Union County, and then it's every day of the week through Towns County. And Clay County also has a transportation availability for those people that may come out positive for transportation issues that are in North Carolina. But the fees, there is a small fee, but we could help take care of that, and there's churches that have offered to take care of transportation issues for our people as well. Churches have been a very big help to our community as far as those that may have a need for any of these domains, and they've been just invaluable assistance to us.
Thank you. Good. Any questions from folks on the line about transportation issues? I know I've talked with a few of you trying to get your transportation hardwired and budgeting.
Our churches, a lot of our churches have vans that they have offered, for transportation for anyone that needs transportation to an office visit, hospital visit, whatever. I mean, they've come out in very good support for us.
Good to hear. Thank you. Thanks for sharing, Dexter. Appreciate it. Okay, I don't see any questions in the chat. Mel, you let me know if we have any comments in chat. Next, I'd like to introduce Candler County Hospital and Shannon Hart. We'll have Shannon unmute.
Hey everyone, I hope y'all are doing well. Can y'all hear me?
Shannon, yes, we can. I have your slides up, and if you want to discuss your slides, and just tell me next slide. And folks, please ask any questions in chat.
Yes, ma'am. First off, Candler County, well, I'm Shannon Hart. I'm the quality manager at Candler County Hospital. We're a 25-bed critical access hospital, and swing bed is actually our bread and butter here. That's the bulk of our patient population. We offer inpatient as well as outpatient surgical services. We have a rural health clinic that is very beneficial to the community, and as well as pulmonary rehab. We have nuclear medicine available. We do cardiac stress testing. And that's pretty much most of our services in a nutshell. So starting off with the health equity, we initially we had we gathered a small team and we conducted our health equity assessment, gap assessment. And that was just to help us identify any areas that we immediately, needed to address. We identified or appointed our social worker as our health equity champion. She is just very resourceful, and this is what she does on a daily basis. So it was just the right person to choose. And she's just a true gem to our hospital and to the community. We quickly identified that our EHR system has a lot of limitations. A lot of data that we pull is manually. It doesn't really run reports for us. So this was a task for us, Ms. Karen. However, our social worker, she said without a doubt, without any data, she knew that our Black population with diabetes, new onset diabetes, or even if they were chronic with diabetes, that was a population that needed to be looked into and addressed. With our EHR system, we knew that we gathered the data. We asked these questions because we looked at the PROPAR tool. We knew that we were asking these questions and we were screening our patients, but there was no formal way of documenting what we did. And even with what Miss Kim, our social worker, the actions that she took to address these issues, it really wasn't being adequately reflected. So our clinical informaticist, she has begun developing an electronic tool to kind of capture this data. And that's just still in the making. With our diabetic population, there's 11,000 residents in Candler County. 22% identify as Black. But whenever we manually ran or extracted our data, we noticed we could confirm what our social worker said. 42% of our diabetic associated admissions were Black patients. And so Miss Kim, she led basically the initiative of bringing in some outside resources with the University of Georgia. It's like an extension. They came in and provided education to the community. So for about 2 or 3 months, they had several basically not even just informational. So they invited the community as well as the staff to come in, and they provided lunch, and it was just a lunch and learn. So they taught us, not only how to manage diabetes, but the focus was more so on nutrition, how to eat. They gave great examples, not only with the lunch provided, but how to do proportion control and how to count calories, knowing the difference between sugars, and it was great information for about 3 months. And we had a really good turnout with that. With Another one of our areas that we identified as a as a as a I'm sorry, y'all, my brain is all over the place. As a barrier was transportation, and I think that's just something that most rural locations, we all just battle that. We do not have a local, well, first off, our EMS is county owned. The hospital does not have any transportation ourselves, and then there's not many local options available for transportation.
Shannon, real quick,
Yes,
Dexter was talking about church vans are very helpful. And
now,
does that help at all?
so what I wrote that down because that's a great option. So we have I call them Metarites. I'm not from this area, but they most definitely know a lot of people in Metter, and this will be something that I'll take back to the team to see if this could be an option or a solution for us with transportation, because we have had people that they can't leave because we do not have or they're waiting for us to have, if we reach out to, I think it's Motor Care, waiting on rides. It's just it's been a tough, it's been a battle, you guys. It's been a real battle, transportation. So that's kind of like something that we've kind of pushed to honestly on the back burner because we honestly don't know how to address it. And it's been a lot of talks. We've had a change in leadership, and this was one of the areas that our new leader, he really wants to focus on transportation because it is most definitely an issue for us. Next slide.
Okay. Well, yes, just a comment. I love that you have the University of Georgia Extension come into your hospital, or you had community education and hospital staff education. Is that correct?
Yes, ma'am. Yes, ma'am. We really enjoyed. I'm not a diabetic, but I provide education to diabetics as a nurse, and so a lot of the staff enjoyed the education as well. They did a great job, and it was nice to know that we have that option. We also found later that our rural clinic, they are now considering a diabetes educator. She has an extensive history as far as diabetes education, and she helped with the Mercy Ministries. That's in a town not too far from here, maybe about 30 miles away from here. She provides education for them as well. So at least we know that we can refer to our clinics. And then these patients that are new onset, because a lot of them were young in age. But at least we know we can refer to our clinics, and then that education continues.
Oh,
Shannon,
great.
this is Mel, and I have a couple of questions around that
Yes,
because
ma'am.
I think that just goes to show, really thinking about what you do have available. So the UGA extension services, those are free to communities, correct?
Yes, ma'am.
Yeah.
And you said that they came in over what amount of time did they come and
It was like,
go ahead.
I'm sorry, I didn't mean to cut you off, Miss Melody.
No, about how often did they come in?
So they came in it was for 3 months. Once a month, they came in and they did a lunch and learn.
Okay,
And they had a different.
You all pretty much, you provided the space for them to come into the hospital?
Yes, ma'am.
Okay, and so, again, that's a free service and something to link your patients, your diabetic patients with. So I think that's great. And, I do know that you have an educator that's working with a couple of your clinics there. So, that's another layer. And then I do appreciate you, calling Dexter out for a good idea, with the church vans, because I think that's something that some communities might have and just don't know they're available. And I do like your term of the what do you call it, Betterites, the folks
Yes,
that
ma'am.
are out in the community and everything. So I think that's good outreach. But a great example there with the UGA Extension Service, something that, every county, I think now still has an extension agent. And so, just trying to get in with them and find out what services are available. So thanks for bringing that out today.
Yes, ma'am. Thank you.
Yes. And Shannon, you also mentioned you had a clinical informatics person.
Yes, ma'am.
But you also have this barrier. You have the CPSI electronic medical record, and it has some limitations.
Yes, ma'am.
Any changes in the future? Do you know of changing medical record?
So our clinical informaticist, she's actually part-time. I think we would most definitely benefit if we had a full-time, but we share her with another facility or hospital. There has been talk with CPSI having a social determinants component added, but everything comes with a cost. I don't know if they have completely designed or developed this component, but I have seen that in the making, or have received information about this being an option as well
Okay,
in the future.
great work. Very nice, Shannon. I'm going to move to the next slide for you.
This is just some quick data. Again, as I said, 11,000 residents in Candler County, 22% identify as Black, and then 42% of the Black population were amongst our diabetes associated admissions here. And then one thing that we did notice was the data that was collected up front, the real data. 15% of that data was missed in collection. And you see the different numbers of what was actually missed, with sexual orientation being high. I mean, that's a question that is kind of it's very personal. I don't necessarily have the SOGI data because it's not really collected here. And we didn't know if that was something that CPSI didn't have built into the electronic system, or if it was just that's even more personal, and I don't want to ask that question. And so we then invited the director of patient access to the team just to get the wheels turning to say, hey, is it a matter of we need to educate staff and prepare them a little bit better to feel more comfortable asking that question? Or do we really need to look at our system itself and see if we're actually able to collect that data? And we are able to collect that data. So we will begin, doing a little bit more education amongst not just our front lines registration staff, but with everyone that comes in contact with the patient, because we all should feel comfortable asking those questions.
Good. As far as SOGI questions, the hospital isn't required to ask or document, especially under the new administration in the White House. So kudos to you for continuing to track it, and then also tracking the percentage that you missed. So that's a great way to look at it. My advice is just to continue. If your hospital says we want to collect SOGI data, go ahead and collect it. But it is not required if you don't want to build it in.
That's good to know.
Does that help? Anybody on the line collecting SOGI data? Anyone on the line? Other hospital, Georgia Flex hospitals? If you're collecting it, have you stopped?
What part is the SOGI data? I'm sorry.
Sexual orientation, gender identification.
We do not. No.
Okay.
Thank you, Bonnie.
Karen, is that the same as the real data?
It is not. The race, ethnicity, and language.
Okay.
So
But
I think that's
continue
a
to
step
work.
further.
we do have a response over in chat. It's a question mostly answered, preferred not to answer, and
Mhm.
Drusilla they do not collect it at Optum either.
Yeah, they'll tell you, I don't prefer to answer, or they skip it or opt out. So if it's becoming burdensome, or you think you wouldn't need to add it to electronic medical record, you don't.
Okay, that's
Um,
good to know, Ms. Karen.
And you don't, I would, for your data, I see Black residents. So continue to, obviously, race, ethnicity, and language. And then you're linking it to the diabetes, education. So that's your health disparity.
Okay, yes, ma'am.
But thanks for putting that in your slide deck. Did you create these slides?
Yes, ma'am. I'm looking now. I'm like, oh my gosh, look at all these typos. So y'all, I apologize.
Oh, I don't see any. I don't see any. No, just great job. That's
Thank
great.
you. And I have
Great
one
job.
more, Miss Karen.
Sure.
That's
Here
the
you go.
last.
One more.
And then this was just our 2025 focus, and it's just us continuing what we're doing. This year, we haven't really seen that many diabetics come through, but of course, cardiac and pulmonary are those kind of go hand in hand. So we would like to continue and just extend the education component, offering education to the community as far as those these three, because those are the top diagnoses that we do see in the hospital at times. With the electronic form that our clinical informaticist had developed, she said that once we get this form to fully develop, she can tie the Z codes that were provided to us for the social determinants of health. She can tie those in, and we may be able to track and pull reports afterwards. So that's just still, again, being developed. And again, with transportation, I'm happy our paths have crossed, Dexter, because I'm most definitely going to share about the local churches, because I do believe that they would be interested. Our ER director has began having some conversations with our local EMS to see if that's an option. But with non-emergent care, you really don't want to tie up our only source for emergent transportation. You kind of don't really want to tie those. You don't really want to tie them up if possible. So we'll most definitely continue looking at some other options. And that's all I have.
Well, that's great. That's a lot. Thank you, Shannon. We so appreciate it so much. And yes, a lot of thank yous in the chat. Appreciate it. Give you a round of applause, everyone. Dexter as well. Thank you very much. I think you've given us confidence and positive vibes to say, hey, contact the church vans, and they can help out. They're willing to help out, provide a driver and the van. And your strength.
They've been
go ahead. I'm
very
sorry,
good at
Dexter. Go ahead.
They've been very, very helpful, and there's a lot of our churches around have vans that they on Sundays. They pick people up that maybe don't want to drive or can't drive. They bring them to church, and then of course they've also offered to use those vans for transportation issues for not only their church members but for anyone in the community that needs it. It's been very helpful.
Great work. Great work. And also, like your clinical informatist, Shannon, that's one of your strengths for Candler County. If she's working at another hospital as well, what can you learn from her to help with some of your challenges, your barriers? Okay. All right. Thank you so much. Great peer-to-peer learning today. We're going to wrap up here. Attestation is reporting period, April 1st, May 15th. If you're reporting, or if you have someone on your team in your hospital, I'm sure you're working on this. Thank you for sharing your hospital action plans, participating in our quality council. We'd like to start putting these slides on our webpage so you can see and go back and access if you need it. So we'll continue the same for May 27th, and Mel and I will reach out to folks. Here's our website, the Georgia Flex resources. I've added the safe use of opioids there. As we move forward, you'll see the concurrent prescribing. All the specs are there. I also found a case study. It's a success story of a blog article. The Cluster Regional Health in Oklahoma was interviewed, and I just really enjoyed reading the article about the safe use of opioids in their hospital. They're a larger hospital, 149 beds, but we can certainly learn. So check out our website there. Other resources, of course, the Rural Quality Improvement Technical Assistance Resource Center and the Information Hub website, Research Gateway, all there for you. And check out our website. Thank you all, and have a quality day. And we'll talk to you May 27th.